Pediatric Orthopedics. So this is the Mark and Jean Abel Visiting Professor in Orthopedic Surgery. Dr. Abel is here. Everyone in this room should know Dr. Abel. If you don't, I have a minute just to tell him what he's meant to this department and what he's meant to me personally. But this lectureship was, and Pediatric Orthopedic Education Fund was created in his and his wife Jean's honor 14 years ago now, 14 years ago. And Mark was the chief of pediatric orthopedics here. He served in many roles as well as including chair of orthopedics right before me. And he has contributed in so many ways to the development of pediatric orthopedics and just pediatric surgery here at UVA over his career, which spanned 1991 to most recently when he retired. But Mark is the ultimate educator. His obsession with patient care and quality is legendary. And we are grateful that he continues to come and spend time with our department, particularly through his lectureship. So thank you, Mark, for being here. And I'm going to turn it over to Dr. Ramnas to introduce our prestigious and illustrious visiting professor today.
So yeah, when we're looking for guests to come for the Mark and Jean Abel lectureship, we're always trying to find someone that would fit in with some of the stuff that Mark does or did as a clinician and scientist himself. And so we thought that Jonathan Schoenecker was perfect for this. I mean, he's really the true clinician scientist. If you look at his papers, he has research papers based on basic research, clinical research, education, everything in between. So he really covers it all. And I thought that'd be great for this. And I think this first talk is going to kind of show some of those aspects. It also highlights some of the diversity that he shows with his work. And that's also true in his appointments. You know, not only is he in the Department of Orthopedics, like us here, we're part of the Department of Pediatrics, but he's also with the Department of Pathology and also the Department of Pharmacology. So that says a lot to the depth of what he's involved with. From an education standpoint, he's involved national level with the POSA IPOS program, which is one of the quintessential like 4-day training programs for both clinicians and residents and things like that. So if you ever get a chance to go to that, it's awesome. But also his expertise, mainly relating to acute phase reactions and things like that, we thought was appropriate for Mark. Because you're always our go-to guy for infection. And so he looks at it in terms of both the infection and also the trauma aspects, which would explain, his chair with the Jeffrey Mass chair. I'm sure is related to that as well. But again, his expertise is amazing. And then even, to sum things up, his clinical experience is great. I mean, if you look at like his comments and things like patients and things, the one that stuck out for me was one parent called him life-changing. That's awesome. So we really appreciate you coming here, spending days here. It's a perfect fit for the Mark and Jean Abel lectureship, and we're really excited. Thank you.
I'm not Jonathan Schoenecker. But I just wanted to say what an honor it is to have this lectureship, and I appreciate Bobby and the faculty for pulling this together 15 years ago. Morning, Dave. I also appreciate the residents putting together the case studies and being involved in this. I think it's interesting that the person who hired me in orthopedics at Barnes Hospital was Jonathan's father, Perry Schoenecker. And I'm not sure what it was that got me hired, but I do remember that my interview was walking through Barnes Hospital at WashU, up and down the stairs, and I guess it's because I could keep up with Perry. He's very energetic and dynamic person who is who still is a leader and formative figure in pediatric orthopedics. So I think it's appropriate that Jonathan, his son, is here, come full circle. Thank you so much for coming. Okay.
Thank you. I really appreciate it. Well, good morning, everybody. So to have a talk about translational science to a group of sleep deprived people early in the morning is difficult. I'm going to make this a lot of fun. We have an amazing life when you think about what we get to do. When I walk in every morning to work, my goal is to make a child's life better, to make it so that parents are less afraid of the disease that that child has, and to discover new ways of taking care of those problems with a team as a team sport. It makes it, when you step back and think about all the things that we do, we are lucky people. And along those lines, something I want to pass on in terms of what Mark just said, last week I got to go back to Washington University, where they just started the Schoenecker lectureship last week. And I want to remind everybody in this room is that the things that Bobby's doing about this, as well as your department, to set up these type of lectures, they're essential for the future of what we do. Every day right now, you feel like that there's a cash register running and you are a taxi cab driver with that meter going and generating work RVUs. To take the moments like this, to pause and to talk about the things that we do and how to do it better, it's absolutely essential. And the infrastructure that, from what I see that you guys are doing here, to have so many named lectureships is the way that we're going to have to do this going forward. So keep that in mind, residents, that when Bobby comes to you after you become attendings and start making money and he asks you for money for these things, make sure you think about investing back into the future of education on it. Very important. So thank you for letting me be here. Today, the main things that I really want, especially the residents, to know about is a framework of understanding the biology of how things like fracture healing actually occur, how our implants and the choice of when and where we put implants in affect fracture biology work, how things like limb lengthening works, and then again, as we just talked about at the end, how processes like osteomyelitis work at the basic science level, and how understanding that makes it so you make different clinical decisions. So to understand what my goal was in terms of setting up our laboratory is the goal was to be completely translational. And the way that I did that is that I would sit in our morbidity and mortality conferences and listen to all the problems where we knew we had key knowledge gaps. And frankly, that's what we studied. So our lab studies why we bleed, why we have thrombosis, why we get infected, and why tissues don't heal. If you really pay attention in morbidity and mortality conferences, that's the crux of about 90% of the things that are presented. And our goal in the lab is to go through all of those things at the pathophysiologic level and provide new insight in how to take better care of these problems. The majority of what we do in terms of our granting is focused on this: hemorrhage, thrombosis, and infection. And in particular, the big things that we have discovered in this area, I think, are going to be fantastic in the future, and that I do not think in 5 to 10 years we'll ever use an anticoagulant again. Is that the problem in orthopedics is not a platelet and coagulation, it's a neutrophil and DNA nets. We learned that in COVID, and the new drugs that are coming out are absolutely fantastic because they're going to calm down that thrombotic phenotype without causing the problem of hemorrhage. In orthopedics, that's absolutely music to our ears. So that part of this has been so much fun, but we're not going to get into that today. The big thing we're going to get into is why we have problems with fracture healing. And much of it comes down to, and what we can do is a conceptual framework of what bone biology is. Who's studying for OIT right now? Oh, look at all those hands. I would put forward that the way that you're studying the biology for fracture healing and memorizing, like, BMP2 and TGF beta and things like that doesn't help you have a framework to practice as a clinician. And so with that, the goal of this is to present to you bone biology in a way that you have a narrative, that you remember the story so that you can make better decisions about this. So as everybody always loves to tease orthopedics, here's a bone broke, bone fix. So the goal of fracture repair, of course, is to make bone. To understand everything about how to make bone in a fracture, you have to know the villains that we have to overcome in order to actually make new bone. So the villains that we have as orthopedic surgeons that we take on, number one, bleeding. Number two, susceptibility to infection. Number three is strain, change in length over length, movement. Number four, hypoxia, loss of vascular supply. Those are the main things together that make it so that we won't heal a fracture. And for that reason, the framework to understand fracture repair is to know a narrative of the biological story as to what overcomes those four things. So the next time that you see a fracture as a surgeon, think of how are we going to overcome those four things? And what are the things that I do that either make it better or make it worse? To get into this, you have to know the cellular responses that are designed to stop these villains. So for much of the work that we do in terms of the survival aspect of the acute phase response, everything is focused in terms of what is there to stop bleeding and to prevent infection. And the biggest thing that we have gotten into on this part is platelets and neutrophils. Realize that in coagulation, the neutrophil should have been named as part of the coagulation system. Platelets and neutrophils are designed to create what is called a damaged matrosome that used to be called a fibrin clot. The problem is that if you call it a fibrin clot, it's like having a wrench store and selling hammers. Is that it leaves out one of the biggest matrices that stops bleeding, and that is DNA. DNA nets coming out of neutrophils by EM is indistinguishable from fibrin. And the two of them weave a matrix that makes it so we stop bleeding and trap bugs. So that part of it is very important to understand in terms of where we're going in the future on this. And the big discovery that we had in the lab about this is forever in the trauma textbooks, it says that fibrin is the matrix that bone is made upon in fracture repair. What we were able to show is that's completely inaccurate. You do not need fibrin to heal a fracture. And the opposite is if you don't remove the fibrin, you do not heal. So along those lines, realize this damaged matrosome is essential so you survive the injury and you don't get infected, but if it's not removed, you won't heal. So we're going to skip all of that part. About 20 years of my life of research, we're just going to throw it away off to the side. We're going to move forward into you survive the injury. Now, for the rest of the talk, we're going to get into how do we heal? How do we overcome strain and hypoxia to make bone? This is where the cellular responses and understanding what happens from the progenitor cell all the way to an osteoblast is a really fun narrative to get. So starting off, you have a progenitor cell. Again, it's going to go through this microenvironment of strain and hypoxia, and the goal is to become an osteoblast. To understand how this happens, you need to know some very specific basic science rules that if you just memorize these, it makes the rest of this very easy. Starting off, we have this very special capillary called an H-type capillary. 2 endothelial cells round, that's it. The endothelial cell is the emperor of all of bone biology. If the emperor is not present, you don't make bone. That rule has never, ever been able to be broken. So when you get all excited and start throwing BMP into a fracture bed, if there's no endothelial cells, nothing is going to happen. It's like taking a seed and planting it in cement. So remember that the endothelial cell is the emperor. Strain, biomechanics in orthopedics is a pharmacologic. Really register that. The best drug that we have to enhance fracture repair is strain. That's a great one to think of as you go through. And then one of my favorites on here, the best bone graft that has ever been made is the hypertrophic chondrocyte. The job of this cell is to produce VEGF and BMP until it is touched by an endothelial cell. It's pretty remarkable. So if we take all these and now put all of this into a context of understanding bone biology, that path from progenitor cell to bone, we're going to put together what's been done in basic science over the last about 50 years in this narrative. Number one, the main progenitor cells come from the periosteum. I love telling our residents the only word you need to know for what specialty you should go into is periosteum. Peds has it, everybody else doesn't. The pericyte, the majority of those cells, those progenitor cells, come from the periosteum. It can become an osteoblast through two pathways, intramembranous and endochondral. Usually when I flash this up, as I'm seeing right now, a lot of people start looking down at their phones and think, oh gosh, I can't remember either of these. It's actually very, very simple. The only thing you need to know in terms of the way that this path goes is ask what the fracture microenvironment is for two principles. The villain. Hypoxia. How many H-type capillaries are there? Strain. What is the strain of that area? And what's been incredible is how much research has been done on this. All you need to memorize is 1 and 3%. Under 1%, you can go intramembranous. Over 3%, you for sure are going to go endochondral. So with that, these pericytes have sensors that are sensing how much strain and how many blood vessels are there. If there's very little strain, less than 1%, and there are great vasculature there, you have great H-type capillaries, that pericyte can differentiate straight into an osteoblast. Consider this a permissive microenvironment for intramembranous ossification. Straight to bone. However, in so many situations that we have, this is reversed. And the main thing to think of is for a pericyte to go straight to an osteoblast, this is a toxic microenvironment. So as you're analyzing this thing, if I've got greater than 3% strain, or there's not great vascularity here, that is a toxic microenvironment for a progenitor cell to go straight to an osteoblast. I cannot do intramembranous ossification. The solution, endochondral. This is where reframing what endochondral ossification is will help you so much in understanding bone biology. The job of endochondral ossification is to treat that toxic microenvironment. So the chondrocytes that are made are there to terraform the fracture microenvironment into something that can go to an osteoblast. So along those lines, you have two chondrocytes that do this. You have the mechanical chondrocyte, which is the same chondrocyte that lines with joints, whose job is very simple. Take and resolve strain. You're going to make as many of these chondrocytes that are required to get you down to 1%. So if you have 5% strain for a long duration, you're going to drive a huge callus. And that callus's job is to get you down to a very objective number, 1%. Then, once that spring chondrocyte has resolved strain, we then move on to terraform that toxic microenvironment to bring in vascularity. And the vascularity is brought in by the biological chondrocyte. When these spring chondrocytes have decided we're at 1%, they change their genetic program and start making tons of VEGF and BMP to bring in these H-type capillaries and to turn new pericytes into osteoblasts. So that aspect of thinking of endochondral ossification as a pharmacologic tool to resolve biomechanics and avascularity really helps you understand the difference between intramembranous and endochondral. So that biological chondrocyte will then bring in those vessels, resolve that hypoxia, and lead to osteoblasts. So think of this now in terms of the things that you need to know. H-type capillary, strain is biologic, and a hypertrophic chondrocyte is your VEGF and BMP. Really helps you think through fracture repair. A couple of other things that have been recently discovered that is absolutely incredible. Mark, the number of times that you went in and just elevated the periosteum to get bone to react. Our observations of this are incredible. In the lucrum, in infection. Here's why that happens. Remember that the periosteum is just basically a fibrous layer filled with these H-type capillaries. What is really cool about the H-type capillary, the job of these two endothelial cells round with that one pericyte on top. Think about that. You have a unit of vessels that has a progenitor cell and a vessel that are so set up to heal anything. When that pericyte is sitting on top of a happy H-type capillary, and this is, by the way, a little side on this, a reason why hypertension is so bad for everything that we do is that you get rarefication of the H-type capillary, you start to get smooth muscle around it, and then the pericyte can't communicate with the endothelial cells anymore. Absolute destroyer of bone. But with this, what is so cool in this biological setup, that pericyte, which is the progenitor cell, it is like a tumor in dormancy. It sits on top of this H-type capillary, and if the endothelial cells are happy, it does nothing. The second it is disturbed, either mechanically by us elevating periosteum, a little bacteria, a little tissue injury, that molecular handshake between the two is broken, and the pericyte jumps into action and proliferates like crazy. It literally is like a tumor. This is also thought to be the origin of where most sarcomas will come from, originating off of this, where it's out of control. It then, in that position, says, what's the microenvironment? And what are the two things it's going to be assessing? Strain and hypoxia. So if we're in a position that we've got other great H-type capillaries around and those pericytes can touch it and there's no strain, then we're going to go direct to osteoblasts, and this is intramembranous ossification. However, if that same process happens and we either have greater than 3% strain or we don't have great vascularity, great solution, we turn into those spring chondrocytes, resolve the strain, turn into the bone bomb, bring in VEGF, BMP, and attract the H-type capillaries. This system is absolutely amazing that this is happening in the x-rays that we're watching of these fractures that heal. We then have to go a little bit Quentin Tarantino on this. So this can get a little bit in terms of histology, a little bit gross. What ends up happening is that there's this incredible relationship between the endothelial cell and the chondrocyte. If an endothelial cell touches a chondrocyte, the hypertrophic one, is in a near-death experience. By almost all markers, it's dead. What's crazy about that cell is that it won't completely die until an endothelial cell touches it, which makes it the perfect solution for making vascularized bone. Okay? The thing is where this is Quentin Tarantino is that the H-type capillary, when it touches it, splits the cell in half and then allows the pericyte to pour itself into that carcass and start making bone from within the old dead carcass of that hypertrophic chondrocyte. I know it's pretty gross. It should be NC-17, when we present these. But so that relationship is absolutely crazy. However, in the last 4 years, what's been determined is that under the age of 10, which is like diseases like Perthes disease are so cool, is if something else can happen is that this cell essentially is dead. The endothelial cell can touch it and it transdifferentiates into an osteoblast, brings it back to life, and then turns it into an osteoblast. Either way, that relationship between the hypertrophic chondrocyte and the H-type capillary is very cool. So before we jump further, just remember these parts. That H-type capillary is the emperor of bone biology. It keeps the pericyte quiescent, but it also is what tells it to go if that H-type capillary is for any reason disturbed. That's what causes our fracture repair response to get going. which is a big reason why if you have a non-union, one of the things we try to do is fracture mimicry. We go in and cut it open and make it bleed. Convince it that, and really what we're doing is just trying to activate this again. If we just had a pharmacologic that we could just inject in to make it so that that system would start, we wouldn't need to do that, but I prefer to operate, so let's stay that way. So that part, remember, the next part is that the osteoblast has to be right next to an H-type capillary to make bone. If it is at all removed from it, it lives for 24 hours. So if you think you're doing autologous bone graft and transplanting osteoblasts, you are not. By all lineage tracing, those cells are dead within 24 hours of transplanting in. You're transplanting in the pericyte, progenitor cells, to try to start this all over. Then the final thing is, and this is where what I'm about to show you is so cool for arthritis, and you could spend 10 years talking about this next part. Spring chondrocytes, which line our joint, have to be close to H-type capillaries to get oxygen. However, they fall under the same rules as hypertrophic chondrocytes. If an H-type capillary touches a spring chondrocyte, it kills it. So when your patient shows up and says, "Doc, I have bone-on-bone arthritis," you can say, "Yeah, it's because your H-type capillaries touched all of your articular chondrocytes, and now they turned into bone." Maybe don't say that part, but the entire process genetically is these spring chondrocytes create a zone, the tide mark, that makes it so the H-type capillaries can come up and diffuse through, but physically cannot get through and touch those spring chondrocytes. If that is broken, that articular chondrocytes, they're all going to turn into osteoblasts. So for arthritis, this slide right here is a huge part of where to go in the direction of trying to prevent arthritis, and we can get into this at the end. And then think of the incredible relationship between the bone bomb, that hypertrophic chondrocyte, and H-type capillary. The entire purpose is to draw in an H-type capillary. But when that H-type capillary gets there, it's going to either kill that cell or turn it into an osteoblast. It's a pretty amazing rule when you think about that. One of the very fun things for me is that one of my older medical students, who she now does spine in New York City, she was watching this and she kept looking at me with this look of disgust. And I finally said, "Rivka, what in the world? Why are you so mad at me about this slide?" And she goes, "Well, here's the deal. If the endothelial cell is the emperor of bone biology," and I agree, get it, "I need you to know that the bone bomb is the empress, because she will make everything that is needed for bone biology and sacrifice her entire life for making that bone." So I do like that analogy here, and remember that is your endothelial cell is the emperor, and the empress is that bone bomb. So now that we understand these rules, this is where it gets really, really fun. Let's go to the long bone and go through fracture. So we have thick periosteum that surrounds, thinner endosteum that's on the inner aspect of that cortex. We have nutrient arteries that come in that supply the vascular network of the metaphysis and the diaphysis. Because of the bone biology rules, remember that these metaphyseal vessels cannot cross through the chondrocytic physis, or it's going to kill all of it. Therefore, in order to get vascularity to our secondary ossification center, we need a separate network of epiphyseal vessels to supply those. So you have then centrifugal blood flow through the cortex, and in the femur, for example, there's about 1 million of these little vessels that go from the end osteal vascularity out to the low flow state periosteum, flowing centrifugal through that cortex. So think of bone as being made and maintained through vascular sandwiches. You have a really important vascular network on the outside of bone, a really important vascular network on the inside of bone. They need to be connected. And at the physis, you have your epiphyseal vascularity and your metaphyseal vascularity, and you have to have both healthy to function. So if we get into bone fracture biology, primary fracture repair is really just about the microenvironment. So say that you are really good surgically and you make an osteotomy that somehow does not actually disrupt the vascularity, which is like the ideal gas law, but really think of it in this way. your pericytes jump off of the periosteum if you have a permissive microenvironment being very low strain and great vascularity. These pericytes can go straight to osteoblasts and you heal. However, as I just said, this really is the ideal gas law. This very rarely ever happens. Instead, we usually have a toxic microenvironment, and this is where we get secondary fracture repair, which importantly is a combination of endochondral and intramembranous, not just endochondral. What that is that we have our fracture, we have strain, we have the disruption of that vascularity. Here's some of our animal models where just a simple fracture in the femur causes a huge avascular area, and we have to overcome all of this. 90% of those progenitor cells come from the periosteum, 10% from the endosteum. The most strain is at the site of the fracture, least strain is further away, and best vascularity is further away, and you have very low vascularity here. So as the rules we just went through, this is very predictable in terms of the type of biology we're going to have in each area. We can get intramembranous in a permissive microenvironment far away from the center of that fracture. We have endochondral because it's a toxic microenvironment that needs to be terraformed before we can make bone. And because of centrifugal blood flow, what ends up happening is we get this huge vascular shunt that the vessels will pour blood out into the periphery, into the periosteum, activate all those pericytes, and through our vascular casting, you can see this incredible network of H-type capillaries that develop that actually are, without an osteoclast, unbelievable at decorticating. This is where we're going in spine surgery now, is that much of what we're doing, our bone grafting is showing is this decortication really is not necessary. It's a natural process of the H-type capillaries coming out of the trabecular bone. This is true in fracture biology, etc. It is a really cool event that is incredible that you lose this cortex faster than a tumor or a infection can do without an osteoclast. So that network develops very fast and you get centrifugal blood flow at the periphery. Remember that the osteoblasts are just going to follow that. So you prime the machine with intramembranous ossification at the periphery. Then where you have high strain, we know to resolve that, we need our spring chondrocytes to get us down below 1% strain here in order to make it so that we can then move on to revascularization of the whole fracture. A little side note about strain for chunking in terms of some of the OIT questions, as well as thinking about some of the other processes we'll go through here. This is a mouse that we have that's awesome. It tattoos itself if it's a spring chondrocyte. So anywhere that's pink is a spring chondrocyte. And what's awesome on this is in the way the mouse stands is realize there's two different types of strain with modifiers that you need to know for OIT. And that is there's compressive strain and there's tensile strain. Spring chondrocytes work the best in compressive strain that is dynamic. Think of a pogo stick. Just continuous dynamic compressive strain makes these guys blow up like crazy. Tensile strain is terrible for them. They can't stand it. They don't make anything. They don't make it up. That's why the initial plating strategies were plate on the tensile side. So think through all that as you see your fracture and how this is going to heal. You now have resolved that first part of the toxic microenvironment. We then make the empress start planting VEGF and BMP and then drag all of those vessels together. In the process, those hypertrophic chondrocytes are either going to die or go through transdifferentiation into an osteoblast, and we get a vascular union of the vascular shunt before we heal a fracture. So here's that vascular union that happens from that vascular shunt. And then remodeling of a fracture, for the most part, is vascular remodeling. So it's the vascular remodeling that turns this back into that original structure with that cortex. So practical applications of this, just flying through these that are fun. Pediatric bone is better. And the simplest way is periosteum. We have far more periosteum with far more progenitor cells, and the ability to activate those is very easy. The transdifferentiation is better, and it just makes it so that pediatric bone has better vascularity, better progenitors than any of the adult type. And the holy grail right now in terms of pharmacologics for adult, like Peter Attia, if anybody reads things like that, rapamycin and things like that, is the idea of restoring us back to a state that we have better H-type capillaries. The whole saying in med school, breathe or die, it's real. So that aspect about having H-type capillaries is very important. And again, that's where many of the areas in fracture biology are going, is how can we harness that youthfulness of the pediatric bone. In terms of surgical technique, it's fun to go through the literature in terms of the progression of this. I love sitting down and talking to my dad about this. He started off at WashU in trauma, and the principles that they had for Mayo at that time was absolute stability and basically go in and strip. I mean, they would take fragments out, put it on the back table, put it back together, and then, put it back in, and they thought everything was right on that. If you look at this now in terms of a zone of injury, if this is the amount of hypoxia that you have, the pericyte only needs to supply cells for this area. Well, if you go in and do massive periosteal stripping or remove that periosteum, your zone of injury is now much, much, much bigger. And that component to understanding how to handle those tissues and trying to keep a periosteal conduit intact on an osteotomy, for example, not completely cutting the periosteum, unbelievably important in terms of thinking about the biology of how this is going to heal. Respect the periosteum. When I was a resident, we had a saying with trauma, and that was for our femoral nails, is go big or go home. The average nail that I put in as a resident was a 13. When you think about that in terms of what we're doing now, it's pretty incredible. And that component is this. Is that if you are nailing, and Truetta was the main one who really was able to show this, is that if you don't affect the amount of hypoxia, that area of the endothelial stripping, you're fine. But as you go bigger and bigger, what happens is you're ripping the endothelial network out, and you're going to make it so that the zone that has to heal in that area, just like the periosteal stripping, is much, much bigger. And that endothelial destroying component of what we do with nailing, you have to be very careful about. So the rules from these biology: respect the periosteum, respect the endothelium. Then endochondral is great in doses. And so as we're going from pericyte to bone, remember that the main thing we all want is VEGF and BMP. I mean, right now everybody throws BMP on just about everything, but realize the endochondral ossification is doing that. So if you go through a biological chondrocyte, you are making tons of VEGF and you are making tons of BMP. Whatever you can do to stimulate that can be very beneficial for the fracture repair. Well, that's where know that you can't get the biological chondrocyte without having the biomechanical chondrocyte, which is why strain is a pharmacologic. So if you drive strain across that area for the first 7 days and build up a huge amount of those biomechanical chondrocytes, and then you lock in strain, you are going to have the best bone graft that you could ever have. Those cells are going to be producing VEGF and BMP until an endothelial cell touches it. It's at the right dose and it's persistent. So when it comes to this, in terms of understanding that, the opposite you need to know as well. Absolute stability in the wrong situation can destroy a bone. And that is because if you are under 1% with your construct, you're getting absolutely no signal to make those biomechanical chondrocytes. And so in that, that's where you get a non-union from too little strain. You might have the biological process there, but without getting the signal of strain, you're not going to drive the fracture biology. So remember that part of it. And Perrin in the 1990s has incredible articles about this. Is biological plating is theoretically you should know how much periosteum is there and where to put your locking screws to make it so you give the exact amount of strain that would drive endochondral ossification in that area. To make it, so that you then, once strain is gone, have a bone graft. That's the purpose of biological plating. It is very difficult when you're looking at x-rays on the bone that you're treating to sit there and completely figure that out. That's where we need great research to be able to say, all right, here's the distance at which I should put those locking screws to get that amount of strain. The problem is that if you do this and you leave too much strain that the cells can't overcome, then you're going to have a hypertrophic non-union. And so this is where understanding that process is so important. Next part of this is where we're going with ultrasound therapy and EM, is that the goal is to find the resonance frequency that drives those prehypertrophic spring chondrocytes to proliferate so that you can mimic strain by just giving pulses and getting it to the point that you drive those prehypertrophic chondrocytes through ultrasound or get real strain and allow your patient to load during that process, especially the first week, to try to drive this up, in order to get it to use strain to get your bone graft. So respect the periosteum, respect the endosteum, use the chondrocyte. The next part of this that's fun to think through is your lengthening. There's no good classification system for the osteotomies that we make. Elizarov was incredible at this and basically described it like this. A nice osteotomy, if you know Elizarov with the chef hat, just picture him with his cigarette in the operating room talking about it. Oh, we need to make a nice osteotomy. A nice osteotomy is one that does not disrupt the periosteum far and leaves as much vascularity intact. When we talk about thermal necrosis, the main thing we're worried about is killing the vascularity. That's the one thing to remember on that. So if you have that vascularity intact and the periosteum intact, remember you're going to get your pericytes for the residents. Which type of strain, if you're lengthening, is this going to go through? Compressive or tensile? Tensile. How much does endochondral ossification love tensile? It hates it. So therefore, these have to heal through intramembranous. So as you're distracting, you need to do this at a rate that you're not outrunning the vascular response. The 1 millimeter per day is not about the bone, it's about the vascularity. So that aspect is absolutely essential in order to get that lengthening right. As Elizarov would say, a not so nice osteotomy is one in which we have a huge zone of injury. Because if we have a huge zone of injury in here, that vascular response being very far away, you're going to need to let that thing sit for 2 to 3 weeks before you start distracting, or there is no way that you're going to get that to heal. And the problem is we don't have ways of detecting that. Our x-rays don't show this. Then, if it's avascular, you're going to try to heal through endochondral, but that tensile absolutely hates that. It makes it, and then you have your very, very bad osteotomy, like the classification system. And that is where you've also stripped all that periosteum off. And there is no way that that is going to heal. So the final thing we're going to go through in terms of practical applications of this is something I think is really important to understand for everybody, and that's infection. So remember that we talked about how a vascular sandwich makes and maintains bone, and that is that the cortical aspect has to have blood supply on both sides. The physis needs it on both sides. When it comes to infection, the problems that infection causes on pediatric bone, all it is which vascularity is hurt. When it comes down to it, is that the cortical vascularity is hurt, you're going to see sequestration. And that's just a definition, which is essentially the end of the diaphysis or metaphysis. If the epiphyseal, and remember I'm saying epiphyseal vascularity is hurt, that's the biggest setup for getting a physeal arrest. So when it comes to it, these are all the same process, AVN and sequestrum, they're all the same thing, it's just in different parts of bone, and they have different consequences. With that, as we talked about yesterday, hobo, you guys remember hobo, 1930s? Tortuous vascularity of the zone of ossification. That's where bacteria typically start. Remember that that area is analogous to fracture healing. So the reason why we get osteomyelitis and fracture repair, same reason as to why kids get it in the zone of ossification of the physis. The bacteria are in an immune privileged area there. They can establish. Typically then they come out and through that centrifugal blood flow, they'll go to the periosteal space and they accumulate. Your platelets and neutrophils come in to kill all of that. In the process of killing it, the collateral damage are the H-type capillaries. They're dead as well. And so this is why we see these really nice areas right here where this is probably where this started. Here's an abscess developed, and this is the beautiful subperiosteal abscess that develops. And your platelets and neutrophils killing that's going to kill that cortex right there. So once you've killed the infection, you now are left with this. And the question is, how does that heal? And everybody has seen this really well. If you're lucky and you have periosteum left, you'll get an involucrum, which is just that fracture callus. So you'll have these pericytes that establish. The problem with this is look at the microenvironment. If the cortex is intact but dead, your strain is less than 1%. This is like putting on a locked plate to a fracture with absolute stability. Nothing would be better than this kid just go out and break this, get some strain. Or we do something to get some strain. We need something to drive the endochondral process here, because otherwise this process takes forever in watching it. And then your metaphysis, if it does heals, is going to be through creeping substitution, which is where osteoclasts and macrophages slowly get rid of that sequestrum and revascularize from in. So if we take a look at this through complete revascularization on an example of this, is here's a mid shaft. You can see that we've ruptured out through the periosteum here. The entire bone is affected. We then are in a state right here. I should have had the x-ray out here before. Is just that I was lucky. This kid was lucky and did go out and fracture. Is that this was taking forever to heal. All of this is sequestrum in here, right? That's the organ failure of bone. But understand that this back here is beautiful. This is the involucrum of revascularization around that sequestrum. So understand this in terms of seeing how this works. And this is the biggest thing to avoid. If you go into breed osteomyelitis, there were lots of protocols. I love, again, talking to my dad about this, that the goal was to resect that infected periosteum from the subperiosteal space. Now you have this. So not only do you have no strain to drive this, but you have no pericytes and no H-type capillaries. So what do we do? How are you going to get this back? Residents, we talked about this yesterday. What do you want to do here? Bueller? Anybody? You can say, you're saying it, just say it out loud. Masquelade. So understand the purpose of masquelade is to make a new periosteum. Induced membrane. So the goal is take that out and put something that is inflammatory. The main biology of vasculae is it is creating an inclusion cyst to make the new periosteum. Macrophages come in and try to degrade that, and they are what creates that neoperiosteum, which is the induced membrane. It is very cool. Once you have the induced membrane, you then can remove the inclusion cyst. And in kids, as long as it's stable, you don't have to put anything in. It's going to regrow. But you can put something that is osteoconductive, inductive, however you want in there, because now you have the cells, and that is what regrows them. It is really cool when you think through this in terms of those principles. So in summary of all this with the bone biology rules, one, for all the residents in here, there's only one subspecialty that you should go into, and that's because we have periosteum. Periosteum is absolute gold. Vascularity is essential. You guys are all vascular surgeons before you're bone biologists. You need to know the vascularity of everything that you're working on, unless you're in total joints where you just do internal amputations. Then you have strain and hypoxia dictate bone formation. Chondrocytes are one of the best bone grafts that you could ever have. And I hope you use that to think through all of the next fractures and every situation that you take care of. And I really appreciate the time being here and look forward to tons of discussions about this.
Do we have any questions?
Just go to
Dave?
Yeah.
I'll let those.
We'll let
you go first.
So the question about the origin of those progenitor cells. So you're talking about parasites. That's very convincing. But if we all remember a debate between Danny Hart, Pittsburgh, and Anna Kaplan.
Yeah.
You know, those are two scientists talking about is it really those progenitor cells from parasites or from bone marrow? So
Yeah.
what's your thoughts on it?
It is so, the best way for me to explain it is that the lineage tracing animals, so those ones that you can tattoo, those are to me by far the most convincing system to use. And in our hands, with almost every situation that we do that's a practical aspect of what we do in orthopedics, that's where we're seeing those cells come from. To prove that, what we did is then create animals that we put a self-destruct into that same cell. And so I can turn a switch on molecularly and kill those specific cells. And when I do, I get no fracture repair. I get no spinal fusion. All of the systems that I play with, I'm pretty convinced that that's where it comes from. The things that we've been doing, we have a paper review right now on spinal fusion that we've talked about with the periosteum, is that if we go into mice, strip the periosteum off, cut it out, electrocauterize it, etc., is that we don't get fusion. So that's the part that, yes, you can identify some progenitor cells by flow cytometry and other analysis that are within bone. But the studies that are more convincing is when you put them in a series like fracture repair or spinal fusion and track where the cells came from that made the new bone are the ones that have convinced me that I think that this is from the periosteum. Can I give a small caveat to that is that as we age and the periosteum becomes a lot thinner, I do think we probably start relying a little bit more on the interosseous progenitor cells. But in the pediatric population, from our clinical work as well as all the animals that I do on the younger studies, is the periosteum is 100% gold on it.
Are the mice that you use in those studies that you're showing with the tattooing, are they typically juvenile mice or younger mice, or have you done it in older mice too?
Yeah, so that's a great question. What you're asking, we like to describe as endochondral efficiency. And there's big differences. I love where you're going with that. And that's the Peter Attia comment, is that when you take like rapamycin and other things that in particular alter the mitochondrial membrane potential of the entire animal, you can kind of reverse that endochondral efficiency. We get far more transdifferentiation in the young animals as opposed to apoptosis of the chondrocytes. And then we have way more of a proliferative response off of the periosteum in the younger animals as we do opposed to the older animals. And certain treatments seem to try to reverse that to make it so that we're more of a juvenile phenotype as opposed to the age.
My reason for asking is, as an adult trauma surgeon who tends to take care of some pediatrics, but mostly adults,
Yeah,
I don't get the periosteum to work with as much.
no,
But frequently, when we're looking at fracture constructs, which now gets into the stress strain area, and differentiating between treating pediatric patients and treating adult patients, we talk about being able to get away with certain constructs in pediatric patients because you have the periosteum and all this healing potential and much quicker time to healing than you do in adults. And so we have to change our constructs. But to your point, we really don't have a strain meter. We don't have any way. We've tried very rough ways to look at strain and stress
And vascularity.
models and things. Exactly. You don't have any way to track the vascularity. And even if you did, you don't know what's been damaged and then how quickly it's going to recover, because some people will recover their vascularity much quicker, obviously. If you look at a smoker or someone with underlying vascular conditions, you know that they're going to be a problem. But other people who seem like they wouldn't necessarily have a problem with vascularity can have trouble with healing sometimes, where we know that that can be an issue. You just don't have any idea of how much damage has been done. We're trying to quantify that with CT scans, looking at comminution, or trying to get a sense of the inflammatory response to an injury, to try and, very, very indirect markers for these types of things that then would give you maybe a score to say, oh, you have a high injury score, therefore your recovery is going to be slower based on the local environment.
So I have two comments. Number one, the easiest solution for you is to take more pediatric trauma calls.
Dr. Ramos would be very happy.
The second is that I when I say I love what we do, I can't tell. And the reason why I made this guy juggling. Residents, when did Rankin make first X-ray machine? Give me more than just a century. Get down to like a decade. 1890s. Okay. One of my favorite things to talk about in regards to technology going viral. All right. When did Legg, Calais, and Perthes publish their papers? No, that was the biopsies. It was 19. It's like 1907. 1907. All right. Would you all agree that Perthes is a pretty obscure disease and pretty rare? All right, three different countries. Within 20 years, the X-ray from discovery to publishing the series of Perthes disease by radiographs occurred within 20 years. Think how long it took just to get the X-ray machine across the Atlantic. It is why we have orthopedics, is because we can see. Incredible. The reason why I have this is the amount of time I've sat there thinking what you just said. This guy juggling this is where we need to go with research. If we could see and understand the stem cell, which is that seed, if we could see and understand strain, and if we could see vascularity in the operating room, we would make so much better decisions about everything we do. Everything that you just said is what we have on this. And that's where thinking of the future of this for residents doing research, et cetera, that level of impact you can get by thinking, how could I measure these things in this trauma?
Well, you can see some of those things. You can see when you do debridement, you have to be very careful. You can see vascular tissue.
Yep.
When you have a fracture, a healing fracture, malunion, and there's callus, you don't want to strip all that callus away. Those cells are important. Everything that you said today gives you a guideline for proper management of fractures, and you can see some of it.
Yeah.
But in a very rough way, right? You can say, oh, bleeding or no bleeding, but you can't say how much bleeding. Can you say, is there enough bleeding? Is there enough vascularity? Because that's, again, when you talk about strain, 1%, 3%, 10%, is it 2.5%? Is it 6%? Is it
Right.
10.5%? Because we think 10% is too much, right?
Yeah.
So, but, that's at any one given time point too, because this is a dynamic process. And if you're talking about, one of your comments was, we should get strain right away. But what do we do after someone has a surgery? Even if we're going to let them weight bear pretty quickly, we put them in a cast for a couple of weeks, get their wounds healed up, settle down. They're usually pretty miserable anyway. They don't really want to move around.
Absolutely.
And so if you said to them, hey, what you really need to do is go move this leg around and maybe walk on it for a week, and then we're going to put you in a cast and kind of slow you down a little bit. That would be a very game-changing way to look at how we do this. Even for, our field is really moving more towards early weight bearing, early activity, because we know that that's a process and that, loading is actually very helpful in many of these environments. But trying to get people to load right away can always.
And that's where I think that the practical applications of ultrasound and EM are incredible.
Stimulators would be great. You could throw on a bone
We're
stimulator for
the
a
way
week.
that the insurance companies right now do it, it's unbelievable, is that you have to show that they have a non-union to get it. And every time, what I've been doing is writing to them, and I'm tongue in cheek on to do it. I include all of our write-ups on this and just say, I need this right from the get-go.
But sorry, I don't want to conversation. So, we were part of the trust study, and the trust study with ultrasound-based bone stimulators for acute tibia fracture did not show an improvement.
And,
Now that was in adults,
and
but
remember what Truetta said about the tibia. My least favorite
Yeah, yeah.
bone in the body because
That's
the
what you said.
vascularity is so bad.
there were almost 500 patients in that study. If there had been an improvement with that, and maybe it's, maybe the frequency's wrong, maybe you're not doing it the right, maybe there's all kinds of things you could kind of get into. But I would have
Absolutely.
expected to see a little bit more signal on that. And we're really,
My concern about that is just that that's not standardized to the variable of even knowing if you have the progenitor cells to work upon with that.
Yeah.
And that's
it's a
the,
very rough application of the
is.
technology. And so you could say that it's the right idea and the wrong application. In the sense of the idea is that you need some sort of stimulation. We just didn't give the right kind of stimulation, or maybe in the right patient population,
Yeah.
or whatever. But it was a little bit disappointing.
it is disappointing. And again, I just get to go back and hope the residents are listening to this conversation. Pediatrics.
We should probably move on.
All right.
This dog.
But that's the other talk, by the way. This is a neutrophil, and we can talk about that at the end. If anybody's seen Talladega Nights, I'm gonna come at you like a spider monkey with, that's what a neutrophil does in a fight. So we'll get into it. All right. All right. Is there a way to move that, can we, okay, he's back there. Can we, get that video off now? The little window.
You should be earlier. It's a new system, so I think it's video layout. So. Sorry.
That's okay.
Yeah.
Oh, you got it. It's off.
Yes.
What, I don't know what you did.
First button, that was amazing. There you go.
All right. This is a talk I love giving for everybody, in particular for, this is really focused at the chief residents. But for everybody on this is going through this. So as I said at the beginning of the last talk, is that we have one of the best jobs in the world. And there are times that you go through and look at all the reports that are coming out in orthopedics and other areas of medicine about burnout. And that is something that, to me, going through this and having the opportunities that I have, you take a step back and say, how can you go into this field and get burned out, given what we get to do every day? But just for a quick show of hands, this is not for the residents, this is for all the attendings in the room. Who in this room as attendings ever got to the point that they felt burnt out from this job?
Yeah.
This is something that I think that we can be really intentional on in terms of taking head on. And one of the biggest facts that I do with faculty development that I find absolutely amazing as I go through this. Bobby, how long did it take before you had a real job in orthopedics? So from undergrad, med school, training.
He hired me, so right out, but 4 plus 4 plus 6.
Yeah.
So 4 plus 4 plus 7.
So
15 years.
how much time do you sit down, and you probably are very different than everybody else, and work on asking yourself, what do I want to do in my life? What's my mission statement?
Yeah, I think
You're different because you have goals on it. When I sit down with a lot of our faculty, it's amazing how many of them don't take any time to do this. This is probably the most important thing to do. Eric, you had what, 5 years of doing that? Of figuring out, what do I want to do? So this part is so essential because of this. For the residents, what does Chicago in July mean to you? So all the attendings, did you hear people chuckling? Sailing. You mean sailing through boards. Chicago in July, if you think about how incredible it is to become a board certified orthopedic surgeon, is in your mind as a resident and through fellowship and the first 2 years in attending, you think, oh, the hard part is totally done. This is great. This is so easy. And I look back at mine as what it took me to get to that. And it's 4 years pre-medical, 3 years med, 3 years PhD, 5 years residency, 1 year fellowship, 2 years of practice, 1 year wellness, living in Wyoming. It was awful. And it was awful, man. My wife, skied a lot. It was just terrible. And 19 years. And to get me to the point of becoming a board certified orthopedic surgeon. And there's a part of you that walks out of that test, especially when you get the letter back, that you think like, oh, this is it. But really, that's the part where you have your independence, and it actually is this. This is one of my favorite passages of almost any book in terms of especially the academic orthopedic life. This picture is from Moby Dick, and it is considered on the verge of chaos. And what this is Ishmael is sitting in a bar in New England before he goes out, and he's describing this painting. And the words that he says is it's as a New England hack was trying to picture paint the verge of chaos. And what he's describing is, I can't tell if this painting is supposed to be absolutely beautiful or absolutely horrible. And finally says, what that painter was trying to do is to delineate chaos bewitched. Show chaos under control. For almost any type A personality, I would submit that residency, if you're really good, is you're really good at delineating chaos bewitched. If you look at a lot of the people in academic orthopedics who are successful, they're all on the verge of chaos. They try to schedule out every single second of the day. And when you win, it's beautiful. And when you lose, it hurts. So that aspect about this, in terms of what you guys are going through of delineating chaos bewitched, it is easy as a medical student. It is easy as a resident. It is easy as a fellow. Because your partners in crime are built in. You're sitting next to each other right now. You're going through this as a group. Your mentors are built in. You interact with us all the time. When you pass your boards, it's like a lemon jumping off of a cliff. The main feedback initially that you get, how many RVUs did you do? It's very different. And reframing that once you finish boards is so essential to remain happy with this. The best day of my life was the day that Susan and I got married. From that aspect, having our kids and watching them grow up has just been absolutely amazing. At the same time that all that happened, I was learning to be a surgeon scientist. Some of my favorite times by far were working with our fellows on a very complex case and spending time with our great group and having an amazing time mentoring some of the youngest and brightest and most naive people that are on the face of the earth. It is just absolutely delightful. With that, if you take a look at our lives, as a surgeon scientist, if I'm being realistic about the things that I do in my week, this is how I spend my time. Is the majority of my time is either taking care of kids, educating, doing research. This is how much time I spend with the best part of my life. Along those lines, when you sit there and look at it, it can really hit hard in terms of how we are, how I have such joy with this, but yet choose to do this. And that part is difficult. One of the most important things to understand is that most of the people in this room have type A personalities. With that, realize type A personalities are incredibly selfish. And what are we selfish about? Time. That's the main thing. One of the biggest lessons that I learned, always apologize. It is not your son's fault that you are a type A personality and selfish with your time that you miss a soccer game. Never give that excuse. There's no way that your son or your daughter is going to look at you and say, can you go do this? And you come up with, well, I got to go put this, this humerus back together that's avascular, and ever have it that they're going to completely have that be a justification for the time missed. That part of this is very difficult. We are always in a pursuit of justification for selfishness. The beautiful thing is that the things that we do are as close as they can come in this world. If your job was just to go get money from other people, it's difficult to sit down and have your spouse talk to your kids and say, well, they're not here for dinner, but they're doing a good thing. They're getting money from other people. As close to the justification as you can get of choosing to do something good in this world, most of the time your family will understand it. The biggest part about this that I learned from the lessons from my wife on all this is this. If I come home and I'm frustrated with the day, I had 20,000 Epic Basics messages, this administrator is telling me to do this is telling me to do that, and I'm late for dinner. Her comment to me is, doesn't make it feel like it's justified. You missed the time with us and you didn't enjoy what you were doing. How does that make any sense? And that part about this of being intentional about what you do and realize that you are in control of your day is making sure that as much as you can day in and day out, you make choices that when you come home, you enjoy what you did and you're happy to tell your family about it is going to be the closest that you can get to justifying your choice of having that time away. It is huge in terms of preventing burnout and enormous in terms of preventing moral injury as you go through this. So that component to it in terms of having the choice of living a life on the verge of chaos and making choices to make it so that the majority of the day you did delineate the chaos bewitched and didn't have the chaos kick your butt is essential for making it so that you avoid these parts. With that, the component that we talk about in terms of wellness, the core factors of this are agency and community. That agency and community is that you do have a role within the community that you work in towards something good that you think is right, and the community that you're moving towards is right. Again, when we talked about this before, is that all this time, this is where it's easy as a resident because you have agency in the community. Your community are the colleagues that you're sitting with. It's designed for you, and the mentorship as to what to do is right here. We're here for you. The harder part is after you finish those boards, and all of a sudden, your agency initially is an Excel sheet with work RVUs, and your community is difficult. Bobby and I talked about this a little bit last night. One of the biggest things we're struggling with at Vanderbilt right now is the new hospital system is spoke and wheel. We have physicians that are 20 miles away, not around anybody. And their main job is to see 50 patients in a day. That agency is to see patients, and the community is the interaction that they have with their patients, but there's not a friend at a water cooler to sit there and say, I just saw this really cool case. You have to be intentional to build this. You need to have the best case ever and have a friend that you can go give a high five to and say, I got to tell you about this case I just did. It was amazing. And the way things are designed right now, you look at what you guys have built here, this thing's amazing for your community. Make sure that you always are intentional about using it. A reason I brought up about the lectureship, that's what these are. Make sure you take advantage of these. Do not make this something that, oh, I got to go listen to this guy talk about osteoblasts, and then I got to run off and see 20 patients. Engage into it. So that aspect of what to do after you have your board so that you don't become Ishmael sitting there looking at this, wondering about your life, is the intentional part of this is to map out your life, create a grid, spend the time to really have an Excel sheet that you know everything of what your goals are, what you're doing. And that is for me, it's a clinical practice, education, research, administration. I know how much my family and the community outside of the hospital mean to me. And then the hobbies that I have, making sure to foster them. That part about knowing yourself is absolutely essential, but we're terrible at this. Navigating how to make sure that you get those every day, every week, difficult. Balancing this is one of the hardest parts, and being dynamic to change when times change, very hard. We don't teach this during residency. This is something that we need to be better about. Here's my biggest advice. For you and your chaos, do not try to take this on by yourself, whatever you do. You need mentors. That mentoring in terms of who is right for you, you need people who have credibility, reliability, and value. The best way to think about it, you need parents. They're indispensable. You need people who will give you unconditional love about developing yourself, that will give you, even more importantly, tough love to say, I know that when you went off and did that, you thought you were happy, but you were miserable. You need that self-reflection. You need people who will provide choices, encourage you making mistakes, and very importantly, showing up. Actually being there, sticking your head in your OR, saying, hey, what are you doing? Those type of things. The other part of understanding this is that there's the word mentor really has 4 parts to it. You need to have mentors, coaches, heroes, and sponsors. The mentor is the person who will sit down and ask open-ended questions to try to help you come to the conclusion as to who you are, not tell you who you are. Your coach is somebody as to once you have decided an area that you want to go into, they coach you how to do it. You need to have heroes who are examples that you look at and say, when I am, for me, it's easy. My father's one of my biggest heroes. Is a lot of people make fun of the fact that he's 84 and still not retired. I love that. I love what we do. I see why he does it. I get it. I need somebody like that because it's unique. And it's who I think I want to be. And then, very important, you need sponsors. Somebody who is going to promote you. You say, I'm interested in getting into this area of hand surgery, and you know you can go to Bobby and you can say, I can make a phone call to the people who are the experts in that field, and I can get you there. One of the most important things in the world that happens with mentorship is where mentorship gets frustrating is when a mentee tries to use a mentor for the wrong reason. Greg Mencio is one of my favorite people in the world. If anybody's met him, he's hysterical. But the guy is the worst Socratic mentor that ever existed on the planet. If I sit down and say, hey, can we just talk about where I'm going in the world? Oh, you're either happy or you're unhappy, or whatever. If I go to him and say, can you coach me on how to do this? He'll talk until the point of me saying, hey, just would you shut up? I got it. I got it. Promotion, he has done so much for my career. It's amazing. And as a hero, I think he's amazing. The first 2 years of practice, I was so frustrated with him because I didn't understand this, and I tried to use him as a Socratic mentor. Understand that as you start figuring out who your mentors are, you need to know which one of them are good for these parts. As a mentor, you need to know what you're good at. If you're not good at sitting down and being Socratic, tell your mentee that. It makes this so much easier in your life. So the know yourself component is my family by far is the best for me on that. I also have had many other people who have been absolutely incredible that I know. I haven't talked to them for years. I pick up the phone and say, hey, Jim Castor, I want to ask you some questions about what I'm thinking I want to do 5 years from now. And he's amazing at asking open-ended questions to make it so I come to the conclusion about it. I've got good friends from residency that I also find that going to conferences are incredible at helping you figure out who you are and who you want to be. Navigating, again, for me, Mensu and my dad, in terms of coaching, the things that I do are amazing, along with my other friends, my department, etc. On the basic science side, I've identified those people who are amazing at helping me out with that. Different conferences I go to. The promoting, I have the list of those people who are incredible at getting me where I want to be. The heroes are people who some are alive, some are in the past. Yuri Gagarin, one of my favorites in terms of first person in space. And then for my heroes in terms of my wife is just absolutely incredible. If I could be as good of a parent as she is, I would be so lucky. So with that, when I say that you need a mentor, understand, I'm not telling you to go find one person. I'm telling you to intentionally think of all the things that you do. Make a grid like this. Take time to fill this out to the point so that when you feel that little feeling of excitement of something new or a little burnout, is that you make absolutely certain you know who to go to in order to get over that part. The other component is to make sure that you become a mentor yourself. Many of the residents are already doing this with the medical students. You don't realize that you are, but you do this a lot. It's the best way to get to know yourself because in the process of people asking you questions in all of these different roles, it causes you to self-reflect on what you need to do. It helps you have that agency in that community, and then the final part of this is work on your mission statement. One of the best things I did through the Positive Leadership program, this is Peter Waters' program, and his thing, what's your walk-up song? What song do you play when you walk into the hospital? Mine's the theme song from Jurassic Park. Every morning, 2 miles away from the hospital, I turn it on. And the thing that Peter had us go through, what I love, is you have to write your my why. And my why is I come into each work today with a clear purpose to improve the lives of children facing musculoskeletal challenges and to ease the fears of their families. Working alongside an incredible team, my mission is to diagnose, treat, and bring hope. And I'm driven by the knowledge that through compassionate care, rigorous science discovery, and a commitment to teaching, we make a profound impact on our patients' lives. For me, pediatric orthopedics isn't just a career, it's a privilege to serve, to heal, discover, mentor, and make a lasting difference. When I do that every day and listen to that song and make it a goal to make sure that I have accomplished those things, when I go home, my wife instantly knows it without me saying a word. The days that I won the chaos, that I delineated chaos Bewitched, I don't have to say a word. She and the kids know it. That part two is understanding the final thing that my wife has to always pass on is this. Our lives are chaos. Realize that their lives are chaos as well. And make absolutely certain that you understand that doing this together takes work. Never catastrophize about if somebody in your family's chaos gets a little bit out of control and it affects your chaos. Don't be selfish about it. Make sure that you don't belittle their components to their chaos. Always listen. Always own your decisions. Never make excuses of saying this as to why you're more busy than they are. Enjoy the chaos if you choose to do this. Understand when it's important to back off your chaos. If somebody in your family's chaos is winning, you need to back off of yours to give time to make sure that they know that you're there for them. Have your ways of getting rid of your chaos. One of my favorites by far are our dogs. My wife and I get up at 4:30 in the morning to take them running. It is one of the best things in the world. We end the day with them as well. It is amazing how much the dogs, no matter what your chaos was, still are happy about everything. Take time to go and enjoy time with your family. Make absolutely certain that aspect about taking time to think about yourself, to know your why is at the forefront of what you spend time doing. And again, make sure you structure your life that you take time to leave that chaos behind you. So with that, I appreciate the invitation of coming here. Really enjoyed. You guys have an incredible program and look forward to helping anybody through any of this that they might need.
We have time for about one or two.
Yes, questions, please. Richard.
I would add one thing to your eye. It's the what you do for yourself situation. So as you kind of get family, the things that you used to do alone can no longer